Thank you all for coming out this evening. I don't get to make it out to East Texas very often, so anytime that I get invited, I jump at the opportunity because I like seeing what's going on the ground. Being in the bubble in Austin, your perception, as you can imagine, can get skewed sometimes, and amplify that when I spend time in Washington. John asked me to come and visit with y'all today about value-based payment, and specifically some of the changes that are coming with Medicare payments. So with that, I like telling my members, first commandment's don't shoot the messenger, because what I'm going to tell you is something you may not want to hear, but it's something you absolutely need to hear. To the point that our board about a year and a half ago directed the academy, directed their staff to begin going out and meeting with physicians as often as possible to prepare them for what the future holds in terms of payment realignment, changes in both Medicare payment and very quickly followed by commercial payers. I could spend all evening talking to you, showing you slides about why this is happening, but I know that some of the other speakers are going to talk about that in terms of federal deficits and the cost of health care increasing at 3 times the rate of general inflation. But I'm not going to belabor that point, but I'm happy to answer any questions that you might have regarding why we are in the situation that we are now. But instead, I'm going to talk about where I think things are heading, where the trajectory is moving, and the opportunities that the Academy sees for our members if they're willing to step up and lead that change. So a broad definition of value-based purchasing or value-based compensation is where buyers hold physicians and hospitals and everybody else accountable to both the cost and quality of care that they're providing. So, when you think about fee-for-service today, where you're on the treadmill and you're just churning patients and no one's really looking at outcomes, whether those things that you're doing is needed or not, whether they're providing value to the patient or not, much less what they're costing the system or not, that's going away. And we're going to be looking at holding physicians and others accountable to both cost and quality for patient outcomes, to reduce inappropriate care that ultimately rewards the best performing physicians. If you think back to what managed care was envisioned to be back in the 80s, it was the insurance companies coming in with these incredibly complex, very costly information systems where they were supposed to aggregate data on how your patients were doing, how you were doing compared to your peers, and they very quickly got away from managing care to managing money. Well, we're kind of going full circle back to better managing care, and the information systems that are out there today are really accessible and available to physicians to put in their office, where they can begin to aggregate patient data, compare their data against their colleagues, to really look at gaps in care, holes in care, opportunities to both improve care and ideally lower cost. So value-based purchasing is not new, but it is the new normal. When you look back at the Medicare Modernization Act, the Deficit Reduction Act, the Patient Protection and Affordable Care Act, and recently is, I guess it's now 7 months ago, the Medicare Access and CHIP Reauthorization Act that repealed the Medicare Sustainable Growth Rate, the Medicare SGR formula that is used to determine what physicians are paid under Medicare fee-for-service. So the new landscape for Medicare cost containment, and again, I'm not going to talk about why we're having a discussion about cost containment, but if you think about 10,000 new Medicare eligible patients coming into the system every day, on a cost trend that isn't quite a hockey stick, but is still, 3 times what inflation is, and the feds and the taxpayers are paying for that, it's an unsustainable trend. So, if you think about the Affordable Care Act or Obamacare, Act 1 was coverage expansion, whether that was the exchanges or Medicaid expansion. Act 2 is cost containment, and that is going to be the driving theme, I think, for the next 10 years at least, until we can figure out how to bend that cost curve down, because we simply don't have the tax infrastructure to pay for the number of people that are coming on to Medicare, much less what the cost of that care that they're receiving is going to cost. So MACRA, the bill that replaces the SGR, provides several automatic increases to physicians, which I will go through in a second, as well as incentives for them to participate in a variety of pay-for-performance programs. So if you think about PQRS or meaningful use, and again, I'll get into it a little more detail in a second. What MACRA does is to set up 2 tracks. So let me talk about those. So the new reimbursement pathways for Medicare payments, and I will preface this to say that generally commercial insurers, as soon as Medicare makes a decision, they're about 6 months behind the curve saying, me too. So Medicare has really added gas to the fire of changes that are occurring in the commercial market. So now the commercial insurers have the cover to say, me too. We're going to follow Medicare's lead. So what the SGR repeal provides for is between 15 and 19, there will be an annual 0.5 annual update for physician services. I know that doesn't sound great. It certainly, doesn't keep up with inflation. But if you think about what the SGR was proposing with the 0% annual inflation, with the potential of I think at the time we repealed it, a 24% reduction in fee-for-service rates, 0.5% from a mathematical standpoint for Congress made sense, where they could come under a certain threshold to pass the bill. After 2019, physicians that remain in fee-for-service will get a 0% update through 2025. But the bill provides 2 payment tracks that offer bonuses starting in 2019. One is a merit-based incentive payment system, which we call MIPS. You got to have an acronym for everything, I guess. That combines PQRS, meaningful use, and value-based medical multiplier into one rate, essentially. The other one, and I think that this is the most interesting and has the most potential impact, is it establishes a pathway for physicians to participate in an alternative payment model, like an accountable care organization or a patient-centered medical home, or some of the other pilots that are being done by CMS right now. So let's look at merit-based incentive payment system. Starting in 19, physicians can see incentive bonuses above the 0.5% in the range of 4 to 9% per year. Now, and I'm not quite sure how they're going to do this or how far down the road that that CMS has gotten, but they're essentially going to determine whether physicians are eligible for those incentives based on quality, resource utilization, that's referrals, cost, home health, all those costly things to our system, clinical practice improvement activities, and meaningful use of certified EHRs. So, you're not going to get a free walk. You're not going to get a free 4 to 9%. There's going to be a lot of effort and a lot of work that's going to go into qualifying for those MIP potential quality bonuses. There's also penalties with MIPS. And MIPS is, I should have mentioned this earlier, MIPS is you're staying in fee-for-service. You're not joining an MA plan, Medicare Advantage plan. You're not joining an accountable care organization. You're continuing to operate in a fee-for-service world. But there are penalties for staying in. And those are going to be for the physicians that are not achieving those four things, the quality resource utilization. If you are on the wrong side of that curve, you will see a 4% potential penalty, 5% in 2020, 7 in 21, and 9 in 22. And both the negative and the positive adjustments are going to be ratcheted around a proportional manner for the scores that are closest to the threshold. So they've got a lot of work to do on MIPS, but they've laid the groundwork. They've shown us what their intentions are. And to me, what their intentions are really to try to drive doctors out of fee-for-service with the penalties and the small amount of potential upside into alternative payment models. So for physicians that choose to participate in APMs, they'll receive a 5% bonus over their traditional Medicare billings from 19 to 14. So again, it could be a patient-centered medical home, and whether you're qualified through NCQA or JCAHO, or there's a couple of other qualifying bodies that escape my mind right now. But you know, it's a way of delivering care that's an enhanced primary care model. Any other model that CMS has identified or qualified under their CMMI, Center for Medicaid Medicare Innovation Center, so that could be bundled payments or some other things that are not happening in Texas right now, frankly. Or shared savings Medicare ACOs. And I don't think I have the slide in here, but I did a talk last week in San Antonio, and I believe right now in Texas there are 47 ACOs operating in Texas. I think 34 are Medicare MSSPs. Maybe 12 or 14 are commercial ACOs, and then you've got a blend of both commercial and Medicare. So they are operating in Texas, and I know Bo's got some experience with one down in the valley that he's going to share with you. So I won't steal his thunder, but it's a great story. And other selected demonstration projects that Medicare's identified. I think one of the big opportunities with the APM model is that it exempts doctors from having to participate in the MIPS and from participating in the meaningful use requirements. They're assuming that if you're going to participate in something that's looking at quality and outcomes, that they really don't care how you get there as long as you achieve those savings or those quality improvements. And you know, the ones that I've dealt with in Texas are, you know, all physician directed. They're all sort of joint decision making in terms of the quality that they're going to measure, how they're going to distribute money, assuming that there are savings. So there's a real opportunity for engagement at the physician level. So as Deming said, or I guess that sign says, change is ahead, whether we like it or not. And there's nothing politically, legally, financially, frankly, that can stop change. And that's just a reality. And as he said, it's not necessary to change, but survival is not mandatory. Or as Mark Twain said, you know, I'm all for progress, it's change that I object to, which is sadly where a lot of our physician members are right now. They're okay with having the system move forward and have more accountability placed on the system. They just don't want it to happen to them. And you know, I hate to say it, but that's just not an option unless you go to, you know, a cash-based system, which, you know, if you can get your patients to go with you, good for you. But for the commercial payers, for Medicare, I think for Medicaid in the near term, this is the direction we're going. So this is a nice little graph that kind of shows where we are today and where we're moving in the future. Again, you know, fee-for-service today, we're going to value very quickly. I think Ms. Burwell, who's the head of CMS, said that by 2019, and maybe it was 18. I don't think 18 would work, but that she would like to see all or 50% of Medicare payments be tied to outcomes and not fee for service. So, the feds have got a very tight timeline for moving the payment system away from fee for service. We're talking about getting out of that sort of cowboy mentality that physicians have been using to deliver care to a more team-based approach. So using mid-level practitioners and other providers within the sphere to the top of their license. There are a lot of things that doctors do today that they don't need to be doing. You are too well trained and getting really bad compensation for things that you don't need to do that somebody else could do. You still need to be the captain of the ship, but you need to figure out a way to delegate those responsibilities. We're moving away from individual care to population care. And one of my really good friends up in Dallas, who's a young family doctor, said something that just stuck with me. He said, Tom, let's say that I have a patient panel of 3,000, and I'm going to see 100 of them in a week. I really shouldn't care about, what those 100 that are coming in to see me are dealing with, because we're going to take care of them, because they're going to come in, we're going to see them. What we need to be thinking about is, what about those other 2,900 that aren't coming in? And what interventions can we do to make sure that they're not pinging the emergency room, having unnecessary hospitalization, going to a specialist or getting home health that's not necessary. That's the way we need to think about how we're going to provide care in the future, because those are the opportunities that we have to, again, improve quality and lower cost. And moving away from the treadmill to a more a model where you're utilizing all the resources that you have, where you're truly satisfied with the care that you're providing and being compensated appropriately for that care. Again, here's another chart that I think really captures the trajectory of value-based purchasing. And I can't emphasize enough the absolute foundational nature of primary care to this. There is no system that I know of, no ACO that I know of, whether it's physician-led, insurer-led, hospital-led, venture capital-led, that doesn't have a robust foundation of primary care physicians at the heart of what they're doing. And if you think about it, when you think about cost in terms of chronic disease management, on continuity, on all the interventions or opportunities that primary care has an opportunity to make a difference, it ain't the anesthesiologist that can play that role. It's not the orthopedic surgeon, cardiologist. I mean, I could go on. I mean, the specialists are in an awkward, difficult position. You're going to see some rate compression occurring in the next 5 years, where rates go down on the high end and rates go up on the lower end. But it puts family medicine and primary care really in the driver's seat, because they have to have you. And they can't do it without you. The other important thing, and I think that the other speakers are going to talk about this, is the absolute critical need for health information technology. As much as it sucks, as much as it is not fun to deal with, what you're dealing with day in and day out, you can't keep up here anymore. The number of medications that a patient is on, whether they need to come back and see you, what specialists they're going to, what problems they have. The technology that's out there today can really help aggregate information in a meaningful way for you to intervene to help your patient. The big issue with the HIT component is that it costs a lot of money. And frankly, a solo doctor, a 3-group practice, a 10-group practice is going to be hard pressed to have the capital to put in the systems that they really need to play in population management, much less care coordination and things of that nature. So we've got to find a way to aggregate our doctors. It doesn't mean becoming employees. It doesn't mean selling out. There are structures that exist that allow physicians to come together in a legally protected manner that I think Bo's going to talk about, that they can share cost and information as long as their main objective is improving quality. Now there's a side benefit to that, because once you have that quality numbers, you can go to the insurers and say, I'm better than everybody in this community. I want a 10%, 20%, whatever rate you want to, argue for, but you got to have the data to do that. And that data, while it's costly, is going to drive you staying in network, as well as continuing to play in this space. So again, I told you don't shoot the messenger, and I hate saying this, but independent practices are going to face a really challenging future, because insurers are being squeezed, and I'm not defending insurers, by the way, but they're being squeezed by their employers to say, hold the line. We don't want any more cost increases. Well, if you've been following what's going on in Texas or around the country, hospital systems are consolidating like crazy. And there's only one reason for that, and that's price. I mean, because the bigger they are, the easier it is for them to dictate what they want in terms of reimbursement. When you look at the pharma side with the new bios coming out that cost $50,000, $100,000 a year, the managed care companies are being squeezed by the hospitals and pharma companies. Their only way to maintain that flat line is on physicians' backs. And, for independent, solo, small group doctors, you're easy pickings, because the hospitals can go to the plans and say, well, we'll take 5% off our fee for service, but you gotta use our physicians that we employ now or are contracting with, as the sole access point for your population, narrow network. Again, the ability to negotiate with vendors for IT support or vaccines or things that really drive cost in your practice. Care management and care coordination is a really difficult thing to do, but when done right, it can be incredibly powerful to keeping patients compliant and out of really expensive settings. I think John mentioned this in his opening, patients want convenience and access. Another one of my doctor friends said, I built my practice around the idea that and this is a terrible analogy, I told him this, but he said, if I went to McDonald's and ordered a hamburger and they said, come back in 3 days, do you think I'd go back? Hell no. So, how doctors offer their patients real-time access, either open access scheduling or e-communications, that is not an easy thing for a solo or small group practice to do. Again, when you think about PQRS and meaningful use reporting, it is extensive and costly, and it's going to be tougher going forward. And again, I'd mention the upfront cost. So, how does the law assist small practices? Well, I think Bo might talk a little bit about this, but the CMS has got $100 million that they're letting out for small practices to really figure out how to participate in an alternative payment model or a MIPS model. And they're sort of seed funding communities like Longview and Texarkana and others around the smaller communities around the state to try to help the doctors navigate what the future holds. And the other thing that I should have mentioned about the alternative payment models is right now on the Medicare shared savings, it's one-sided risk, and that's upside risk. So if you don't save money, well, you're not getting penalized. If you do save money, then you're getting a benefit from that. I think that in the very near future, or maybe 5-7 years, and that's near enough for me, we're going to move to a two-sided risk agreement where doctors are going to be going back to a capitated model. But the time frame that we have right now gives you the opportunity to experiment, to see what works, what doesn't, and there's no penalty if what you tried doesn't work. So, and they're seeding you with additional dollars to experiment, which is kind of a cool opportunity. So I don't remember where I found this, but I loved it. And that's, without broad engagement, family physicians will become passive victims of changes shaped by others, sound familiar? Rather than active drivers of a better future for their patients and their colleagues. The challenge, and this is all about physician leadership, is getting from the way things have always been to the way things will be without tumbling into the fiscal chasm of the way things are now.